The human race has always been at war with bacteria. But the development of antibiotics in the 1930s and 40s gave us the upper hand over the bugs that were killing us. Suddenly, we were superhuman.
Prior to that, they were used to bacterial meningitis, 100% mortality. Bad pneumonia, 30% mortality. Appendicitis or ruptured bowel, 100% mortality, unless you had surgery. The only cure really was surgical intervention to cut the infection out.
Antibiotics allowed us to do things that no one could have dreamed of doing historically. They've allowed us to transplant organs. They've allowed us to undergo chemotherapy. They've allowed us to receive therapy in intensive care units when we're critically ill. Without antibiotics, none of those advances in human medicine would be possible.
We've still got the upper edge. Clearly, antibiotics still work, but it's the speed of change that concerns me. 20 years ago, this wasn't an issue. Today, it's a real issue. Infectious disease kills more people than cancer. TB kills 5,000 people a day. So if we don't start to act soon, start to put our pedal on the gas pretty soon, within another 20 years, we could be in serious trouble.
We've deployed our antibiotic defences far and wide, while the bacteria have kept up their counter-attack. They adapted and evolved. Now even our last precious antibiotics are surrendering to the rise of the superbugs.
I was feeling good. No problem, no symptoms, no nothing. I was feeling really great.
As his 60th birthday approached, Joel Beckler was feeling fit and enjoying semi-retirement. His career in Australia as a stage technician was winding down in favour of travel through Europe and spending a year in Bali with his partner, Roseanne Schock. During a brief return to Australia, he thought he'd better get a checkup.
Getting 60, you think better to have a good checkup. So I went to the doctor, and among the checkup was the prostate checkup, and feel a hard lamp there and say you better to go to urology. And I went to urology and they say, oh, you better to have a biopsy done.
It's a procedure undertaken by tens of thousands of Australian men every year. A special device passes a thin needle through the wall of the rectum to take a prostate sample. To prevent infection, antibiotics are taken. It's usually over within an hour.
The procedure was on Friday morning. By Saturday to Sunday night, 2 o'clock, that's when I started to shiver, and so I thought, okay, well, I've got the infection, better to go to the hospital. We took the ambulance to the hospital and discovered that the preventive antibiotic didn't work, and infection was spreading in my body.
The infection spread from Joel's prostate to his shoulder, spine and hip.
The first pain was in the collarbone. That was the very first one I noticed. Then the lower back pain started to come, and the hip, right in the hip joint, very, very strong pain. The pain was really horrible.
Standard antibiotics had no effect. Joel had a superbug.
I think within 10 days, the pain in my collarbone was so bad that they decided to operate it to do a scraping of the abscess in the collarbone. And then I basically lost touch with reality for about a month because of the painkillers.
Joel spent 3 months in a hospital bed on rare antibiotics imported from overseas. His body wasted away. Now he's trying to regain his strength while fighting off the last of the infection.
Obviously it has been a progress because I'm standing up and I can talk to you and whatever, which I wouldn't have been able to do only a month ago. A month ago I was in pain and screaming in my bed, so it has been a big progress.
Somewhere in his travels, Joel had consumed a virulent strain of E. coli bacteria. It survived harmlessly inside his gut until it was unleashed by the prostate procedure.
This one's not too bad.
No, you look all right. I knew that it was a strain of E. coli they hadn't dealt with before and that they were trying their very best to try and find something that it would respond to and that would have an effect, but I wasn't sure at times whether it was going to work or that his organs would cope with the bacteria and the antibiotics and everything else, and that he would come through it actually.
Did you fear for his life?
Yes, at times I didn't know that he was going to make it or not.
Now we know that people who've returned from overseas, in some of these hot spots where resistance is very common, and it's in the food supply and it's in the water supply because of misuse of antibiotics mostly in those countries, that we've had a whole string of men after their prostate biopsy now getting superbugs into their bloodstream because we've introduced it into their prostate not knowingly, and it's then spread into their blood, and then they've got incredibly sick.
With 1 billion people now travelling the world each year, bacteria are more mobile than ever before. And so are superbugs. They're born when we abuse antibiotics, and we're doing that across the globe.
Every time we take an antibiotic, we're giving the bug a chance to become a superbug. So if you think about you and the community, you know, the more of us that take antibiotics inappropriately, the greater the chances in the community a superbug will come.
Australia, I think, out in the community is pretty bad. Rates 7th in the world for overuse of antibiotics per capita. Australia's like many of the other developed countries. We saw development and wealth equaling ability to use antibiotics, and we lost the plot in terms of realising, well, most sore throats are due to viruses. They're not going to respond to antibiotics, but I want my antibiotics.
It's the Indian subcontinent which is proving to be a superbug's perfect petri dish. Antibiotic abuse is rampant here.
In India, antibiotic overuse is a serious problem. There's no antibiotic policy in the country, but of course there are many countries where there is no antibiotic policy, but I'm concerned about my country and there is no antibiotic policy.
India mass produces antibiotics and sells them cheaply. The drugs are available over the counter without prescription. Waterways and even the soil are contaminated by waste from antibiotic manufacture. On top of poor sanitation and chronic overcrowding, it's fertile ground for antibiotic resistance.
There is a general principle in treatment of infections. The more we use any antibiotic, the quicker the bacteria are going to become resistant to it. So if we have a situation where antibiotics are used in agriculture, where they're available over the counter, where in hospitals there's very little control over their use, clearly in that environment there's going to be a more rapid spread of resistance.
When more and more patients in Indian hospitals began dying from untreatable infections, local microbiologists began to ask why. Working with international researchers, they identified one of the most dangerous superbugs the world has ever seen. They called it New Delhi metallobeta lactamase, or NDM1. It's a gene that can turn bacteria, once easily destroyed, into untreatable killers.
The NDM bug is really scary because you only have to drink 1 or 2 of those bugs, and they don't have to multiply in themselves. They just have to spit out the little bits of genetic material that make them superbugs, and then they convert all your healthy bacteria into superbugs. So it's a bit like putting a red t-shirt into the washing machine of white shirts. And the t-shirt itself doesn't have to multiply, it just has to leach out this stain, and it changes all your white shirts into red shirts and converts them into a superbug.
India's researchers were shunned at home for bringing the country into disrepute and threatening a multi-billion-dollar medical tourism industry. Chennai-based Dr. Abdul Ghafoor is one of the few Indian doctors prepared to speak out.
We need wartime measures. We can't wait and watch. What we need urgent wartime measures to rationalize the antibiotic in all countries. Government should take initiative and ask the medical community to use the antibiotics very sensibly. Government should bring in strict laws to rationalize the antibiotics in countries. There must be strict antibiotic policies on one end. On the other end, government should talk to pharma industries to stimulate the research on antibiotics.
The drugs that they were treating me with seemed worse than the infection, because the infection, I didn't even know it was there unless they told me. But apparently it was so dangerous that they had to go to that extreme levels of treatment.
David Ricci travelled to India last year to volunteer in the slums of Calcutta. A walk to an orphanage one morning changed his life forever.
Me and my group kind of stayed like a single file line, and I was in the back of it. And so we didn't hear the train coming, and it like hooked my right sleeve and kind of threw me in front of the train and hit me and ran me over, and my leg got caught under the wheel. So I'm directly underneath the train, kind of head first. And it pulled me probably about 30 meters or so before it stopped. They had to back the train back over my leg because it was kind of stuck up in the wheels, kind of. And they pulled me out, and something punctured like my lower abdominal region, and it was probably about, yay long. And there's a lot of internal bleeding, and my femoral artery in my thigh started spraying and gushing blood all over me and stuff, and I was in shock, obviously, instantly.
Miraculously, a passerby managed to stop the bleeding. David Ricci was bundled into a cycle rickshaw and taken to a local clinic.
They started just putting water all over my leg and just kind of washing off all the dirt and the filth, because when they pulled me out of the train, they set me in the trash, because that was kind of the only place not on the tracks that they could put me, and so I was just covered in filth and this black gunk all over me, and so they were washing all that off, and then he took out like a big leather bundle of knives and untied it and pulled out like a big medical knife and just started cutting my leg off.
David was in so much pain those first few days that he didn't want to live. Within a few weeks, he was in a hospital back in the United States.
It's so good.
Blood tests confirmed he still faced a danger even greater than being hit by a train and losing his leg.
A couple days later, they came in, all suited up, and they're like, sorry, we kind of need to quarantine you because you have a lot of dangerous infections that we haven't seen before, and we need to figure out how to treat this before you can do anything else.
David was infected with several types of NDM1 bacteria.
So what's happened with NDM1 is this particular gene has been able to jump around very, very quickly. It likes to get out and about, if you like. So it's jumped from one bacteria to another. It's jumped from one country to another very, very quickly. And that's why it's quite a dangerous bug, the NDM1 gene that's in all these different bacteria. The other key thing, of course, is there's only really one antibiotic left now that can kill this NDM1.
To date, Australia has dealt with fewer than 10 cases of infection by NDM1 type bacteria. The superbug is kept inside tightly secured laboratories, like this one at the University of Queensland.
When you look at one of the superbugs, it's the same type of bacteria, but this one has acquired those genes, the NDM1 gene. What you can see now is these powerful antibiotics that were being used before just aren't working at all. The bacteria is just ignoring them and growing quite happily in the presence of the antibiotic. The one in the middle here is the only one we've got left, that antibiotic called colistin, which can kill this particular superbug.
So will this superbug eventually defeat that antibiotic too?
Yes, it will. We haven't seen that in Australia yet, but overseas there are some cases where this particular bacterium is resistant to all antibiotics, including this one in the middle.
So you're only really buying some time?
Yes, we are.
Colistin was the only drug that worked for David Ricci. It was abandoned decades ago because it was too toxic.
I was only able to be on it for so long before my kidneys and my white blood cell count and everything started dropping. and they had to pull me off right before most of my organs were unretainable. And so at that point they figured that it had worked because they didn't see any signs of infection. There was no fever, no irritation around the site, and so they figured that, well, I guess the infection's gone. But they left a track open in my leg, which we cleaned out every day, and it was just causing extreme pain. Like it was worse than India. It was, a 10 out of 10 pain, and I would just scream every single morning.
You would just see every day he would just go downhill, and very pale and lethargic, and at times I felt like I was losing him, but it was from the antibiotics, and they didn't even know if they were going to work. So it was a hard time, a really hard time.
And my doctors were like, all right, he should still be in this much pain. What's going on in there? So they surgically went in and looked, and it was all black and infected. So they're like, oh, well, it's back.
The tenacity of infections like NDM1 threaten not only individuals, but the very future of modern medicine.
I think the worst nightmare for a hospital would be that not only is there an outbreak of these particular infections, but they become entrenched. They're an ongoing problem for decades to come. That really changes the whole game in terms of ability to deliver high-quality medical services, to deliver transplantation or chemotherapy or intensive care medicine.
Melbourne's Austin Hospital faced this challenge last year when it agreed to accept a patient infected with a superbug. Nick Chameleonis picked it up while holidaying in his native Greece.
I've been the last 5 years 3 times to Greece. I have beautiful time, beautiful country for holiday, nice weather, enjoying myself 80 days. The last 10 days, I come sick.
Nick ruptured his bowel and required urgent surgery. He was soon overcome by infection.
I feel tight, outside 38, 40 degrees, hot. I like to put me 5, 10 blankets.
In the end, he was in hospital in Greece for 6 months, 3 different hospitals, multiple operations to save his life, and ended up with lots of abscesses inside his abdomen, but was finally stable enough. I mean, Nick he's a tough nut, and he was well enough to get airlifted back to Australia. We knew that he had these superbugs in his bowel, but also in all these abscesses. Essentially, they were untreatable.
At the Austin, Nick was kept in strict isolation.
There was precaution taken, and it was a harsh time for the family. Dad was quite, isolated and was in quarantine for the length of time he did stay at Austin, which the family felt, we felt for him.
Doctors struggled to find a combination of antibiotics which could kill Nick's superbug without killing Nick. Just like MDM1, this superbug was sharing its antibiotic-resistant gene with other bacteria.
Now, what's interesting is this is a strain also from the patient, and this is a different bug. It's called an E. coli, and previously this was sensitive, and you can see in this case that it's also growing quite well. I'll just carefully look. You can see it's pink though.
And that agar is full of antibiotics as
Full
well?
of antibiotics.
It's become a superbug.
So what's happened is that this Klebsiella strain has transferred its resistance gene to normally sensitive E. coli and turned this into a superbug, and this is from the same patient.
In the end, the infection could not be stopped. The only cure available was from a time when antibiotics did not exist. Nick's bowel was removed.
We were still not able to get on top of all his abscesses. And so in the end, there was a long discussion with the surgeons to say, look, maybe we should go back to the pre-antibiotic way of doing things and just cut it all out. In the end, we said to him, look, there's a 50% chance you're going to die on the table, on the operating table. If you don't have the surgery, you're dying in pieces, and where I mean, my view was that he had maybe a 3% chance of living for another 6 months. And this was just for him, let alone all the risk to the greater community, you know. So essentially we had to take a pre-1940s approach to cure him. But that's an example of where we're headed. Unless we do something about this, there'll be more of him for sure.
Now I feel like before, exactly. I can tell you more better. Now I don't feel nothing, I do everything. I see the doctor sometime in the hospital. I can say thanks, saved my life.
You know, it can happen to anyone. It happened to my dad, certainly can happen to anyone that travels or that's away from home. And yeah, it is a scary thing. And if surgery wasn't an option, then we'd have nothing. And we wouldn't have my father today. So it's a worry and it's scary, yeah.
At the beginning of the 20th century, tuberculosis was Australia's biggest killer. Antibiotics helped bring it under control. Today, Australia's rate of this bacterial infection is one of the lowest in the world. Indeed, it's easy for us to believe that TB is a disease of the past. But here in Papua New Guinea, right on Australia's doorstep, not only is TB thriving, but Superbug TB has already crossed the border. Most Australians wouldn't know it, but Superbug TB bacteria are living here at Cairns Base Hospital. They're surviving inside the lungs of this young woman from Papua New Guinea.
How I got this TB, like it's an airborne disease, and the people you talk with, like you stand with somebody and talk, like you don't know that the person got sick.
Katharina is currently Australia's only known case of extensively drug-resistant tuberculosis, or XDR-TB.
There's many people for TB, and some are dying for TB.
It's her 5th month inside this isolation room, which she's very rarely allowed to leave. Negative air pressure keeps the disease contained. Anyone entering must wear a mask.
So this here are the tablets?
She's on medication at the moment, pretty stable, but unsure as to what the outcome's going to be in the next months and years, as the cure rate is fairly low and there's about a 40% chance of death from this disease despite treatment.
Dr. Stephen Vincent is a TB specialist based in Cairns.
We've got a lot of cases of drug-resistant TB in Papua New Guinea, and now we've got extensive drug-resistant TB, which wasn't even around 10 years ago, and now it's worldwide. And Australia has a case currently up here in Cairns, and also there was a case, I think, 2 years ago. And I believe there's about 3 or 4 cases of extensive drug-resistant TB in Papua New Guinea at the moment. So if you don't get onto these early and it gets into the population, that's the disaster.
To understand why Katharina came to be receiving treatment in an Australian hospital, we went to Papua New Guinea. The rate of TB infection here is about 50 times greater than Australia's. About 3,000 people die from TB in PNG every year, around 1 every 3 hours. We travelled to the island of Daru, the dirt-poor capital of PNG's Western Province. This is the father of the woman in Cairns?
Yes.
It's here we found Katharina's father, Abraham.
So I was very upset. I was very worried about it. She was losing weight fast. At my own expense, I had to take her to Cyber. It cost me a lot of money. And just because I loved my daughter and I wanted her to get better. So I had to take her to Cyber.
At their closest points, the Australian islands of Saibai and Boigu are only 5 kilometres away from mainland PNG. a 10-minute ride in a speedboat. Unfettered two-way travel is permitted for locals under the terms of the Torres Strait Treaty.
People don't realise, but there's about 50,000 movements back and forward between Torres Strait Islanders and the PNG nationals due to traditional purposes, so there's no gate there. It's a porous border.
For the past 7 years, Australian doctors have staffed TB clinics on the islands.
Breathe out.
They treated infected people from Papua New Guinea.
Okay, stay like that.
But in June this year, the clinics were controversially closed. With help from AusAid, PNG is now trying to manage its TB patients on its own.
I would say that we are doing much better now than it was before.
Daru Hospital is the main centre for TB treatment in PNG's Western Province. Dr. Rendi Moki is the chief physician.
We are more than confident that we can take on board all the patients that have been handed over to us and the current patients on the ground. We have the capacity with very good support from people, our stakeholders, very good support from AusAid, very good support from World Vision. Good morning. Morning, morning.
Built in 1963, Daru Hospital is badly run down and always busy. Dr. Moki leads us through to the outpatients clinic, where suspected TB sufferers are first diagnosed.
Good morning, good morning. Any patient we suspect may have TB and is coughing, we isolate them, give them a mask to prevent transmission to our staff as well as the other patients.
So this is the first line. When people first come to the hospital, they come here?
Yes, this is the point of entry, if you like, to the hospital.
So far, AusAid has spent about $1.5 million improving this hospital. It's part of an $11 million aid package over 4 years, aimed at boosting TB services in the Western Province.
So this is typical of TB chest X-ray.
The money has helped pay for a new X-ray machine and training to use it.
So this is our GeneXpert machine. It has 4 slots.
Within 2 hours, this new machine can determine resistance to one of the 6 types of TB antibiotics.
So it tests for 4 different specimens.
But it still takes months before multi or extensive drug resistance can be confirmed by a laboratory in Brisbane.
It may take more than 2 months before we can know that, but it's controlled because these patients that we diagnose here, we take them and we isolate them while we initiate treatment. They're given a face mask and we isolate them in our TB wards, so it reduces the chances of transmission, and again they are commenced on drugs.
Dr. Moki showed us around Daru Hospital's TB wards.
Wear your mask, please. Wear your mask.
Here, the concept of isolation is a loose one.
We encourage them to wear masks, and they are expected to wear a mask when they're in the ward to prevent cross-transmission. And we also encourage our staff to wear masks as well. And we discourage guardians from coming here. If they do come, they have to come with masks. And
so everyone in here is meant to wears a mask?
Yes, we expect them to wear a mask, okay? TB patients. And by wearing mask, it prevents transmission by 50%.
Makes a big difference.
Yeah, it makes a big difference.
Outside, Dr. Moki explained the very beginnings of the hospital's brand new TB ward. It's also being paid for by AusAid and is expected to be finished next year.
It will be 22 bed space ward, and it will be 6 isolation for drug-resistant TB, including MDR TB, XDR TB, and 16 bed will be general TB, those sensitive TB.
When Dr. Moki left, we returned to the TB ward. Most patients were now unmasked, and the special isolation room for extensively drug-resistant patients was suddenly empty.
On the 15th month of treatment.
From the sister in charge, we learned that one woman in this multi-drug resistant ward was actually suspected of having extensively drug-resistant TB.
So which one of these girls is XDR?
Antonia.
Antonia is XDR?
Yes, suspected.
And why is she in the MDR ward?
Because in the isolation room, we got only 4 beds available in the isolation room.
Is that a bad idea for infection?
Of course it is, because If she's confirmed to XDR, then she can spread it to the other patients.
Anton Narua is the Deputy President of the region's local government. He's just learnt that 2 of his nieces are here with TB. One of them is Antonia, the girl with suspected XDR TB.
That's why I'm saying they're all going to die. They should separate them, but they're all mixed up together. I know my 2 girls are going to die. They're definitely going to die. There is something wrong which I can't explain. It happened to a lot of people. My 2 girls are going to die.
Anton Narua is also concerned about the fate of villagers living far away from Daru along PNG's southern coast. He took us to meet the people of Sigabadru. It takes 2 hours and the fuel costs $350. That's way beyond the means of people used to making quick trips to islands like Saibai, where Australia's TB clinic has shut its doors.
Over there is Saibai, just only about 4 nautical miles from here, 3 nautical miles.
It's very close. And how long does it take you to get there each day?
It takes me only 10 minutes across by 60 horsepower outboard motor.
AusAid has provided a sea ambulance to help bridge the distance between outlying villages and TB services in Daru. It cost about $500,000. It's meant to travel up and down the coast, dispensing TB drugs and checking on the sick. Since it was delivered in May, Sigabadru's villagers say it's only visited them twice.
Okay. I am Mr. Berry, representative from community, and I would like to raise a concern on shutdown of the TB clinic at Saibai Island.
The community of Sigabadru is not happy about the closure of Saibai's TB clinic or the service it's getting from the new sea ambulance.
Only twice. Since then, it has completely stopped it. But we would like this one to continue.
The new TB strategy in Western Province relies on health workers living in these local villages.
Is there any sickness or disease?
They depend on Daru.
There was no patient that has been taken to Daru. All the patients are here, even those who are on treatment.
Goigaranu has been Sigabadru's health worker for 15 years.
When was the last visit you got from the sea ambulance from Daru bringing drugs to the village?
In June 27, that was the last visit. And they said that they were going to come in August 3, but they never did. We are still waiting.
Have people here with TB run out of drugs?
Yes, they have run out of drugs and they're still here in the village.
Had any drugs for 3 months or something?
TB sufferer Sabdu Samai got her drugs from the Australian clinic on Saibai Island.
Yes.
She's since run out.
Yes, the last drugs were supplied at Saibai. And the last clinic, the speedboat came to visit the patients. And they advised that on August 3 they will come again and check the patient, but then they never did. And then patient's medicine's finished, but she's still waiting for doctor's review.
So you need to see a doctor?
Yes.
And when did you last take drugs for TB?
September 1.
About a month?
Yeah.
It is our concern. We really want these patients to continue their treatment.
Is that how you develop MDR and XDR?
Certainly, MDR and XDR do develop through the non-compliance.
Yeah.
Australian doctors who worked at the Saibai clinic say Sabdu Samai's case was referred to Dr. Moki for further treatment.
I'm not sure which patient you're talking about, but we are well aware of our drug-resistant TB patients on the ground at the moment. So those are the ones we have on the list, and we are following up on that.
I guess this is what to point out, it's very difficult to do, but is there a danger of not maintaining?
No, the system is doing what it's supposed to be doing. And this is we just started a year ago, and these are the initial phases, okay? As I've said, we are very much aware of our challenges. We are very much aware of our shortfalls, but we are working on it. We are not neglecting that, we are not ignoring it.
Without faith in their own TB treatments, more Papua New Guineans like Katharina may seek care in Australian hospitals. She was diagnosed with multi-drug resistant TB in Saibai in 2010. With relatives in Cairns, she chose to travel here for her checkup rather than remain in Daru.
From Daru, I flew to Port Moresby with my medication, and I stayed there for 3 months. And while waiting for my visa, I ran out of medication. And by the time I flew here, I got sick.
Her Australian doctors now believe that 3-month break from treatment may have led to her developing extensively drug-resistant TB.
Here we have one that's called pyrazinamide, one that's called isoniazid.
Treating XDR-TB requires a toxic drug cocktail.
This one here can cause severe psychosis in 20% of people.
If she survives, the cost of Katharina's treatment could reach $1 million.
And this one here can cause a lot of arthritis. The majority of the medications are in tablet form, and there's one of them that's through a drip, which you'll probably need to be on at least 12 months. So that's 12 months in hospital, away from her family and friends, and at the moment she's still considered infectious, so she's in isolation.
So her treatment might cost $1 million,
yep,
and she could still die.
Yeah.
The Australian TB services on Saibai and Boigu Islands cost about $600,000 a year.
The cost of those clinics up there was nothing, so economically it makes no sense. If Papua New Guinea's got big problems with TB, which it does, and increasingly now with not only MDR, multi-drug resistant, but XDR TB, why wouldn't you nip it in the bud by running clinics on those islands to stop it getting into the Queensland population? New York City struggled with XDR-TB. You know, they had a bunch of docs and nurses die from XDR-TB. Even throwing the best resources they could at it, people still got infected and couldn't be cured, even despite having parts of their lung cut out. So it's a worry.
We're going to get to an era where there's a phenomenon called totally drug-resistant TB, and this is where it comes to telling these people that we have nothing to offer you, we can't treat you. And the unfortunate thing is that while they're dying from that disease, they're probably going to infect others. So on a public health point of view, it's better off not treatment and they go off and die alone. Sounds harsh, but unfortunately we're going to be dealt with this phenomenon probably in the next decade or so.
Pharmaceutical companies aren't about to save the world from total drug resistance. They have little financial incentive to produce new antibiotics.
Not so long ago, there were 18 pharmaceutical companies developing new antibiotics. There are now 4. And the reason is that antibiotics are fantastic drugs. You take them for 2 weeks and you can cure the infection. And they basically don't make much money for pharmaceutical companies. If you take Lipitor, a cholesterol hypertension agent, you take it for the rest of your life, it's a very profitable drug. So the economics are wrong. And that's why here we are stepping up. If the industry isn't going to look at new antibiotics, it's really up to institutes like universities and research institutes to start to take that fight to the superbugs.
The few new drugs in the pipeline are refinements of antibiotics we've already discovered.
These new antibiotics, which I expect will become available in the next 2 or 3 years, are completely inactive against the NDM producers, the very bacteria that we're likely to see in Australia because of our geographic proximity with Asia and the Indian subcontinent.
What are the implications of that?
So the implications are basically we will have no antibiotics left at all to treat some patients. Therefore, it really rests on us to do surveillance for those infections and for us to put into place very strict infection control measures to prevent person-to-person spread within our hospitals.
In some form or another, we need a central reporting system for these superbugs. We need to go back to basics, improved hand hygiene, proper cleaning, bleach cleaning of hospitals. You know, bleach is a wonderful product. It kills HIV, it kills all viruses, it kills everything. In fact, when we introduced bleach cleaning to the hospital here, one of my professors said, "Lindsay, do you mean the hospital's going to smell like it used to in 1980? And I said, "Jeff, yeah, like before we ever had superbugs, So proper cleaning. We need proper hospital design, 1 bum per toilet. And we need a set of national guidelines for invasive procedures to stop those superbugs getting into our bloodstream.
Defence may be our only offence in a world where antibiotics no longer work.
If we've got no antibiotics left, we've only got one option if we're going to save the person's life, and that is to eradicate the source of infection, to eradicate that area of infection, and that means radical surgery. And clearly that's going to impact many people's lives. They're going to be amputees, they're going to have had significant scars from major surgery in situations where previously we would have used an antibiotic and those measures wouldn't have been necessary.
Since he was hit by a train in India, David Ricci has had 5 operations. Each of them have cut away a bit more tissue. It's now been almost a year since his last infection.
They've always said that it could come back, and it could even be lying dormant right now. So, you know, it could come back at any time.
I wouldn't say it's all the way out of the woods, but I definitely have experienced that feeling of recovery. You know, I'm walking on my prosthetic, I'm going back to school finally, which is something I've been wanting to do since India. I'm just kind of living my life, and if the infection comes back, it comes back.
There isn't an infinite number of antibiotics, just like there's not an infinite amount of rainforest or coral reef. It is a very precious national resource. It's getting tougher. There are fewer companies in the race to discover them, but in the meantime the superbugs are going up and up. So this is what we call the perfect storm, and if we don't start to take action very soon, the problem's just going to get worse until we go back to the pre-antibiotic age.